Hello, welcome to Scratching the Surface. My name's Kamron. I'm a social work student at the University of Toronto, and I'm doing my practicum placement at Recalibrate Therapeutic Services. In this video, I'll be covering diabetes and its impact on mental health. But before starting the video, I must say that if you suspect that you may have diabetes or that a family member or someone you know may be developing it, then please consult with a physician or diabetes specialist. There are no physicians at Recalibrate Therapeutic Services, only social workers who may assist you with mental health support and talk therapy. So without further ado, let's jump into it. So here's my presentation on diabetes, coming to a better understanding as a helping professional. In this video, I'm going to go over the foundations and essentials. What is diabetes and what causes it? Then I'm going to focus a lot more on the mental health aspect of diabetes. What does someone with diabetes go through mentally or psychologically? And how can we, as social workers or people in the helping professions, help someone with diabetes or treat their mental health or psychological concerns? Okay, so what is diabetes? Diabetes is a condition in which the body either cannot produce insulin or cannot properly use the insulin it produces. Type 1 diabetes is when the pancreas produces little to no insulin, and it's often diagnosed in childhood or adolescence, though it can be diagnosed in adulthood. And type 2 diabetes is when the pancreas produces insufficient insulin or the body is unable to properly use the insulin. And this is often diagnosed in adulthood, though it can be diagnosed in childhood or adolescence. The difference between these two is that type 1 is an autoimmune disease. And it's found in 5 to 10% of the population. And type 2 is a metabolic disorder, and it's found in 90 to 95% of cases. And insulin, of course, is the hormone that regulates the amount of sugar in the blood. And if blood sugar is too high, it can cause damage to the organs, blood vessels, and nerves. Okay, so now that we have a general understanding of what diabetes is, we may ask ourselves what causes diabetes. And contrary to popular belief, it's not something that someone can just give themselves, like just by consuming too much sugar. Type 1 diabetes is often caused by a genetic predisposition and environmental factors. And for type 2 diabetes, it has a lot to do with family history, ethnic background, living with obesity, little to no physical activity, poor diet, chronic stress, and lack of sleep. And there are other risk factors that have to do with lifestyle choices. But I just put a star beside ethnic background. I just wanted to mention that Black, Hispanic, Indigenous, and Asian backgrounds have a higher risk of developing type 2 diabetes, and it's just that genetic predisposition. But we can also think of social determinants of health, and that's something I'm going to touch on later in this video as well. So now that we've come to a decent understanding of the causes of diabetes, we can talk about diabetes distress, which is we're getting more into the mental health domain when we're talking about diabetes distress. So diabetes distress can be described as the negative emotions of living with diabetes. Some of the examples here that I put on the slide are like powerlessness, being overwhelmed by daily self-care demands, the fear of hypoglycemia or hyperglycemia, and worries about complications of diabetes. You could imagine that someone who develops type 2 diabetes, as you saw, the causes could be like obesity, not much physical activity, poor diet. You could imagine that someone could feel blameworthy or guilty for just some of the lifestyle choices. Also, smoking is one of those risk factors. So it's easy to feel down on oneself when they have diabetes, and it's something that really takes over someone's life because they really have to watch what they eat at that point. They have to count carbs. They can't eat all the same foods anymore, while the average person without diabetes can eat anything that they really want, and their pancreas just manages their blood sugar levels for them. While someone with diabetes has to constantly make sure that they are between these levels of hypoglycemia and hyperglycemia. And so I've put here that hypoglycemia is when blood sugar levels are below 70 milligrams per deciliter, and some of the symptoms are shakiness, dizziness, and confusion. And hyperglycemia is when the blood sugar levels are above 180 to 200 milligrams per deciliter. And some of the symptoms there are frequent urination, increased thirst, blurry vision, and trouble concentrating. And you could imagine, someone who maybe doesn't understand the consequences of being hyperglycemic or hypoglycemic, they could become, confused or have trouble concentrating or have blurry vision and not really understand the impact that it has on their relationships, on their social life, things like that. And even worse, when we think about worries about complications and some of the anxiety that it causes people with diabetes, the possible complications include kidney disease, foot and leg problems, so ulcers can form. They can get eye disease. They can possibly go blind or partially blind. And it can get as bad as getting a heart attack or stroke, nerve damage, amputation if like an ulcer in their foot or their leg gets bad enough, and erectile dysfunction, which of course affects sexual health, which is even more frustrating. And it can lead, again, since all these things are tied together, mental health can be impacted by that as well. Something else to consider for people with diabetes is that they may also be experiencing mental health conditions or physical health conditions concurrently, which may also contribute to diabetes distress. Some examples I've put on the slides for mental health conditions include depression, eating disorders, anxiety disorders, substance use disorder, insomnia, and increased risk of Alzheimer's disease or dementia in older age. Some physical health conditions could include hypertension, obesity, thyroid disease, chronic pain, and increased susceptibility to infectious diseases and gastrointestinal problems, especially since people with diabetes, their ability to recover or heal from injuries and infections is compromised. So, how can we, as helping professionals, assist people with diabetes? Well, one way is opening and facilitating group programs. And researchers in Copenhagen pilot tested an intervention called the REDUCE program, which sought to improve psychosocial outcomes and reduce symptoms of diabetes distress. REDUCE consisted of 5 bi-weekly 2.5-hour small group sessions of 6 to 10 people experiencing diabetes distress. Groups focused on diabetes education, positive adaptive strategies, sharing personal experiences with diabetes, topics relating to managing diabetes distress, reflections and new insights, and much more. And you can imagine in such a group program, it allows for people with diabetes to vent their frustrations, to really share their experiences with each other, and to talk about the impact of diabetes on their social lives, their professional lives, their relationships. And it must be very validating for people with diabetes to talk about that with others who definitely understand their pain. And also to learn maybe strategies and techniques or ways to manage their own situations from other people who have the same condition. So some of the quantitative results, they found a reduction in diabetes distress and improvements in quality of life and emotional regulation. And some of the qualitative results include a safe space for sharing and understanding previously unarticulated concerns and emotions, which is interesting because only in such a group is where these concerns and emotions become articulated. This group provides that sort of space for people to talk about these concerns and emotions that they were having. Relief of negative self-judgments, increased relatedness and reduced feelings of isolation, new perspectives, and activation of positive adaptation strategies. So overall, this program seems to have been a success, and there should definitely be more of such a program in the community. Another group program that showed promising results was launched by researchers in Cyprus, and it was a weekly 2-hour group session consisting of 9 people with diabetes over the course of 5 weeks. The sessions focused on a lot of the same information and topics that were covered in the REDUCE program that I just talked about, and the results showed that 70% of participants rated the program highly beneficial, with many indicating that they became more attentive, relaxed, and constructive in their approach to managing their condition, as well as a perception change from seeing it as a burdensome illness to a manageable condition. So this is another seemingly successful group program that addressed the mental health component of people with diabetes. And again, it serves as a forum, serves as another safe space for people with diabetes to come together and talk about their condition and talk about how it impacts them and support one another. Besides group programs, as well in the literature was a systematic review and meta-analysis of the effectiveness of CBT interventions on diabetes distress. The researchers in the study reviewed 22 randomized controlled tests, which are basically the gold standard when it comes to research, involving traditional CBT interventions, and found significant improvements in symptoms related to diabetes distress in most of these studies, with less significant improvements in others. And some of the conclusions that they came to was that CBT was found to be effective for significantly reducing diabetes-related distress overall and symptoms of depression. But only third wave CBT interventions for diabetes distress served to reduce levels of anxiety. And third wave CBT interventions include psychotherapies that focus on mindfulness, acceptance, personal values, and cognitive diffusion to build psychological flexibility, such as acceptance and commitment therapy, dialectical behavioral therapy, and compassion-focused therapy. So this shows that it's not just group programs that benefit people with diabetes, even individual therapy can help. And as social workers or as psychologists, people in the helping professions, people who can do therapy, it can be helpful to know some background about someone with diabetes and what diabetes is and what kind of mental health problems someone can have with diabetes. As we reach the end of this video, I just wanted to touch on the inequities of accessing healthcare for people with diabetes. Earlier, I mentioned ethnic background and social determinants of health, and if we're to consider Black people and Indigenous people, for example, who are disproportionately overrepresented in the lower class in this country, they're more likely to experience food insecurity and some of these financial, geographical, and social barriers that make it harder to access healthcare for type 2 diabetes. When we consider systemic racism, prejudice, and discrimination, this certainly stresses people out. And for Indigenous people in particular, from Diabetes Canada, it's stated that Indigenous peoples are diagnosed with diabetes at a younger age, have more severe symptoms when diagnosed, face higher rates of complications, and experience poorer treatment outcomes. And a factor into that is definitely, the legacy of residential schools, the 60s scoop, and ongoing colonial policies that make it difficult in general for Indigenous people to access healthcare. Some of the geographical barriers were mentioned in this article concerning diabetes self-management in Alberta's First Nations communities. And one of the geographical barriers was that just transportation, just getting to somewhere where they sell nutritious and fresh fruits and vegetables. This posed a significant barrier. As well, a financial barrier for them was that sometimes an insurance plan would cover some of the necessities to treat their diabetes, but sometimes it wasn't enough. And for example, they needed needles to inject insulin, and sometimes the needles were not enough, and they would have to reuse needles, which puts them at risk of infection. As well, for one respondent, they said that their vision was getting blurry and they needed glasses, but glasses weren't covered under their insurance. Something else we can consider when it comes to accessing healthcare is that some specialists like chiropodists, podiatrists, orthotists, and ophthalmologists are seldom publicly funded, and that would have to come out of pocket. And for people living paycheck to paycheck, this is just not a reality. And sometimes they have to leave certain aspects of their treatment neglected. They have to neglect that in favor of making rent or paying for necessities for themselves and their families. The estimated out-of-pocket costs for someone with type 1 diabetes was almost $20,000 and $10,000 for type 2 diabetes. And while national universal pharmacare is a positive step in the right direction, I think it's incumbent on social workers and people in general to ask for more from our elected officials to provide better access to healthcare for those who need it most. And in this case, for people with diabetes. But that's just scratching the surface. If you'd like to learn more about diabetes, the links to the sources that I used in this video are in the description below. Again, if you suspect that you or someone you know may be developing diabetes or may have it, then please consult with a physician or diabetes specialist. As well, if you're interested in group programs like the ones I mentioned in this video, you may reach out to a healthcare center near you and see if they offer such group programs. And as always, if you're seeking mental health support or talk therapy, then don't hesitate to reach out to Recalibrate Therapeutic Services, where the experienced mental health practitioners can help you with non-judgmental and compassionate care. Thanks for watching, I hope you learned something, and I'll catch you in the next one. Take care.